available afterwards. We post them. I am the host. My name is Janet Callahan. I am Dean of the College of Engineering here at Michigan Technological University, which is in the Upper Peninsula of Michigan. Tonight's Husky Bites has been sponsored by Jim Schluck Beer, class of 1969. Thank you so much, Jim, for supporting our students with and sponsorships of Husky Bites go to student scholarships unless you direct otherwise. And just for your information, these are also live streamed. If you watch it on Zoom, you can ask questions by using the Q&A feature down at the bottom. If you watch it by joining on Facebook, you would find the Michigan Tech College of Engineering Facebook page, and it's live streaming right now. And so welcome those of you who are on Facebook. Welcome to Husky Bites. And these are accumulating, these are posted also on Facebook, and they're accumulating thousands of views after the show. So it's awfully fun to be hosting these, and thank you for joining us. So I was sharing as we were just chatting before we got started that I was invited to Mechanical Engineering's hockey suite upstairs, and what we're seeing right here are John Scott on the left, the tallest person. Then you're seeing Bill Predebon, chair of mechanical. You're seeing our Husky mascot, and then you're seeing Joe Berger. And these are two of our incredible Michigan Tech athletes who then went on to be in the NHL and NFL. And we raffled, or Bill raffled, 2 jerseys that were signed by each of them. And so we had really good fun up at the suites. And unfortunately, we lost that game, but we did win the one the night before. And so that was overall a great set of 2 games. So another just piece of news, Winter Carnival's over, and we just got some exciting news last week that 3 Michigan Tech Engineering alums were elected into the National Academy for Engineering in 2022's group. And I'm going to just say a few short words about each of them. So first, Dr. Sarah Ryola, who's originally from our area up here in the UP. She was honored for innovations in engineering education. I know Sarah personally. She's retired. She was dean of the College of Engineering at Iowa State University for many years until she retired, and is just a wonderful person and has volunteered for a whole bunch of enormously important engineering organizations. So we're very proud of Dr. Ryola. Second, chemical engineering, Bill Hammack, otherwise known as the engineering guy. And if you haven't heard of him, you might want to Google that. And he's got a YouTube channel now where he originally started in public radio, and then he's kind of shifted media, and now posts free things where people can learn about engineering on his YouTube channel. So, and Bill earned his BS in chemical engineering here at Michigan Tech. And our third National Academy electee is Samson Jenkins, who is currently a professor of chemistry and the Boeing Martin Professor of Chemical Engineering at UW, which is the University of Washington. And he has distinguished himself across his career as well. And so I am very proud of Michigan Tech for having 3 NAE inductees. And then just up next, February 21st, we're actually going to be learning about where the rubber meets the road. This is about the incorporation of recycled materials in terms of road materials. And Zen Ping is a really gifted speaker. We'll be joined with his PhD student, Kobe Jin. And if you're interested in sponsoring a Husky Bites webinar, all you have to do is send an email to engineering@mtu.edu, and it's very much appreciated. And a quick update, last week we featured the Superior Ideas and the engineering aerospace team. And then there was a plea for fundraising, and I want to thank our Husky Bitesers, because in that one night alone, we moved our gifts from 13,000 to 20,000. We still have a long way to go, and so I've put the link up here in case anybody would like to give this evening. And this would count as sponsoring Husky Bites. And so the URL is there, and Sue will also put that in the chat so that you have it easy. And with that, I am going to stop sharing screen, and I'm going to introduce faculty member, Dr. Hoda Hattum, assistant professor in biomedical engineering, who will then be introducing Brennan in a second, but a few words about Hoda. Hoda earned her Bachelor of Science in Mechanical Engineering from the American University in Beirut. She then earned her PhD in Mechanical Engineering from Ohio State, and then had an American Heart Association postdoc fellowship. And she completed postdoc training at both the Ohio State University and Georgia Institute of Technology before then joining us at Michigan Tech in fall of 2020. And Brennan is her PhD student, and she is an expert on lots of things to do with hearts. And I'm going to turn it over to her to introduce Brennan and take it from here. Thank you, Hoda.
Thank you, Janet, for the introduction. I'm going to share my screen. And let me display it. Okay, so you could see it. So I would like to highlight that we have a Twitter handle for our lab where we post our updates. So if anybody is interested to know more about what we do, to see our progress, our activities, our achievements, we are very active on Twitter. And we also have our own website on MTU's website as well. So please follow us if you are interested to know more about us. So this is the Biofluids lab. Currently, what we do is we assess the flow and we correlate findings with clinical outcomes. And more on that will come in the next few slides. And the areas that we are interested in are structural heart defects, congenital heart defects, and arrhythmias. Our lab is mostly involves basically graduate students and undergraduate students. And this is Brennan, who is with us today, Brennan Vogl. He's a second-year PhD student. He joined last January 2021. And he will give a tour of our lab where we do experiments, although the talk today is about computational work and not experimental. So I'm going to stop sharing my screen so that Brennan can get the chance to share the lab.
So hopefully everyone can see here in just a second, but I'm currently in the biofluids lab here on campus. And what we're looking at right here is our tabletop left heart simulator. It kind of gives you an appreciation for just how small the heart is, but as you can see, we have a bunch of devices and quite a large setup just to simulate only half of the heart. So that's a little bit of what we do for our experimental work.
Nice. And Brennan, you earned your bachelor's here too, right?
Yep, so that's correct.
In biomedical engineering?
Yep.
Nice. All right.
Okay, so back to our presentation. So basically what we aim to do in our lab is to answer this question. And this question is really complicated and challenging. Can flow predict cardiovascular disease? And this is why we're going to talk about a particular cardiovascular disease, that is atrial fibrillation. So on this slide here, I'm showing a map of the world where we can see some contour plots. And this is the age standardized incidence rate of atrial fibrillation occurrence. So we see that in the United States, we have the highest age standardized incidence rate of atrial fibrillation, especially from age groups that go from 65 to 78. Now, I'm going to ask you a question. How many new cases of atrial fibrillation were diagnosed in 2017 alone, you think? And you're going to have a poll so you can guess that.
Well, and so there's 4 choices: 500,000, 1 million, 3 million, 10 million. Well, and so Hoda, can you just explain? I've heard of atrial fibrillation, but I'm not sure I quite know what it is.
Yes, so it's coming in the next few slides.
Okay.
Yeah.
I think it's when your heart just is going da 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 da, right? It's sort of not.
Yeah, irregularity. It's a type of arrhythmia. Yeah, but
Okay.
in the next few slides, we're gonna go over everything.
Well, and people are voting. They're clever enough to know that it's probably B or C. So they're predominantly going for C, but I'm imagining this is a pure outright guess. Knowing, you know.
Well, C is the right answer. So 3 million new cases
per year.
Yeah,
And this is
3
in
million.
the United States or worldwide?
This is globally. This is globally, yeah. In the United States, it's expected to really be significant. Currently, we have about 6 million overall, but it's expected to like multiply by 2050, multiply significantly by 2050. So what is atrial fibrillation? We heard about it, maybe we heard about it somewhere, but what is really atrial fibrillation? So for that, I prepared another poll so that you can see these two EKGs. So one of them is for a healthy patient, and the other one shows, and the other one is for atrial fibrillation. So I believe nobody is gonna get that wrong. So let's see. And EKGs, by the way, they measure the electrical signals. So, and this is primarily how we can diagnose that. So yes, the majority of people said that it's figure B, and indeed it's figure B, because if we look at A, we see a nice and neat pattern on the EKG compared to some chaotic patterns. So a healthy person has an EKG that is characterized by waveforms that follow these patterns that are called PQ, RS, and T. While when we have atrial fibrillation, you see that the rhythm is all over the place. We have chaos. We don't have anything that is replicating exactly as it should be. So what really happens there? So what happens is the following. So this is a longitudinal cut into the heart, and you might be familiar with the fact that the heart, a normal heart, has 4 chambers. We have the right atrium, the right ventricle, the left atrium, and the left ventricle. And these dots that you see in the right atrium, these are the pulmonary veins. So the pulmonary veins, they bring the oxygenated blood from the lungs, they fill in the atrium, and then this valve between the atrium and the ventricle opens to channel this flow into the ventricle. And then as the ventricle contracts, the oxygenated blood goes to the whole body to nourish the cells and the organs. So this is briefly what it's supposed to happen. And in order for these contractions to happen, we have here these pacemaker cells. So a heart has its own electrical wiring, if we want to put it this way. So these pacemaker cells, they produce an impulse or impulses, electrical impulses, and they are conducted. And this is what leads to the contraction. Now, what happens in atrial fibrillation is that some normal impulses start occurring, and usually it's believed that the pulmonary veins are the source of these abnormal impulses. So once these abnormal impulses start occurring, then the atria and the ventricles start being out of sync with each other. So this is how it looks like, basically. So this is a regular one, and then this is how it is out of sync. So we're seeing the effect of atrial fibrillation compared to a normal, very organized, very in sync beating, if we want to say. So this is the difference between regular versus irregular heartbeat. So now, what are the symptoms of atrial fibrillation? How can someone tell that they have atrial fibrillation? Unfortunately, sometimes there is no symptoms at all. And recently, like these smart watches that people started wearing, they've been really useful in diagnosing or in detecting some abnormal occurrences or arrhythmias, for instance. So I have seen a lot of cases. Basically, we read about them, of patients who showed up and they were like, my watch detected that I have an arrhythmia, or my watch detected atrial fibrillation, but I was totally fine. I was exercising and I was totally fine, which is really fantastic. But if we don't have a watch, and if like an arrhythmia is really occurring, elevated pounding heartbeat is one symptom, irregular heartbeat is another symptom, a chest pain, shortness of breath, and extreme fatigue. Now, having said that, arrhythmias can occur with a normal heartbeat. So it's not necessary that that we have it, and that's why it's sometimes hard to detect. So what are the common comorbidities of atrial fibrillation? So definitely age matters. Also, we have obesity. We have hypertension, coronary artery disease, diabetes is one, COPD or chronic obstructive pulmonary disease, chronic kidney disease, valvular heart disease, among other factors. And I want to quote a collaborator of mine at Mayo Clinic who always reminds me that AFib is not an isolated disease. It's basically a symptom of a more global disease. Now, atrial fibrillation comes in different types. We have 3 types, and there are sometimes some subcategories. We have paroxysmal, which means that the atrial fibrillation lasts a few minutes to hours, and the rhythm can resolve on its own after a while. We also have the persistent, which means that the heart rhythm does not go back to normal without a treatment or medication. Permanent, which means that the normal heart rhythm cannot be restored. It's a lost cause, and we need medication to prevent clotting. And now that we mentioned clotting, this is a very important adverse outcome, or maybe an outcome associated with atrial fibrillation. So all this abnormal activity leads to the formation of these blood clots. And why blood clots are bad? Because they can simply travel, they obstruct a vessel in the brain, and they lead to strokes. And this is where the dangers of atrial fibrillation lie. So what are the major health risks associated with atrial fibrillation? So we have stroke, we have potential heart failure, and along with other cardiovascular events. However, I think that stroke is the most dangerous of them all. And how do we evaluate the risk of stroke? We do that through this score that is called the CHA2DS2-VASc score. And I'm posting here this link that if you click on it, it will take you to an online calculator where you can calculate the CHA2DS2-VASc score of a patient. So in that calculator, you'll be able to input the age, whether the patient has a history of hypertension, along with other different comorbidities, or even events like previous strokes, for instance. And the higher the score goes, the more likely that stroke will occur. So how does atrial fibrillation impact survival? On this slide, we are showing some data from a study by Benjamin et al. And this data shows the percentage of subjects dead in follow-up versus the years of follow-up. And this follow-up is up until 10 years. And we are showing 4 curves. We have the men atrial fibrillation, which is this top curve, women atrial fibrillation, and then men without atrial fibrillation, and women without any atrial fibrillation. So AFib group is up, no AFib group is down. And we can clearly see that by the 10-year time point, we have a huge difference in mortality rates. Even after 1 year time point, we have a huge difference in mortality rates, which shows that AFib really has a huge negative impact on survival. So now we established that when AFib happens, then we have some abnormal heart rhythm. This can lead to abnormal heart rate, and clotting can occur as an adverse outcome. So when we want to think of how to manage atrial fibrillation, probably the first thing that comes to mind is I want to restore the rhythm. So this is one approach that is logically should logically be followed, right? And this is what this trial is about. It's the AFFIRM trial. And in this AFFIRM trial, clinicians were not sure whether rhythm control versus rate control is the way to go. So we're showing here these results from the AFFIRM trial. And on this graph, we're seeing the cumulative mortality in percentage versus the years. And this is up until 5 years. So if you look here at these 2 curves, you will see that at first, we have them almost the exact identical, right? Up until like 1 or 1.5 years. And then we're starting to see a split. So with the rhythm control therapy, more deaths occur. However, if we want to look at whether they are significant or not, they were not very significant. So what does that mean? And anyway, this trial involved paroxysmal and persistent atrial fibrillation, which are the two of the 3 types that we introduced in the previous slide, and all of these patients were anticoagulation positive. So what can we conclude? Can we conclude that they are interchangeable, that we don't care about what therapy to administer for a patient? What happened is there has been some stopping of anticoagulation in some patients after their rhythm control was administered, and this led to some strokes, which can be one reason why we saw more mortality in this group compared to the rate group. In all cases, multiple studies happened after that, and rhythm control basically won over, if we want to put it this way, rate control. So antiarrhythmetics are the medications that are currently administered. Another method to restore heart rhythm is cardioversion. And cardioversion operates like like a defibrillator example, except that we don't use huge voltages. Instead, they are small electric impulses that go through. This whole operation takes maybe 45 to 1 hour tops, 45 minutes to 1 hour tops, and the patient can just go back home. Unfortunately, sometimes the rhythm doesn't stay regulated, so there might be some more cardioversions to be redone. Now, what's gaining momentum to restore heart rhythm, normal heart rhythm, is catheter ablation or ablation, because it can be surgical as well. So it can be either invasive or non-invasive. And there can be different techniques for that. So for instance, there might be some use of heat or cold energy to scar the tissue. And therefore, when we have these abnormal impulses that we discussed at the very beginning of this presentation, then the scarring of the tissue will prevent conduction. And therefore, there is no contraction that is abnormal or irregular. So this is basically how ablation works. And in order to understand it more, especially on the transcatheter side, I added this video here so we can watch it together. Okay, the video isn't working, unfortunately, for some reason. Okay. Okay, it's no big deal. It was just a very nice visual to show how the scarring occurs and how the electric impulses can be stopped. And the whole procedure of ablation is 1 to 2 hour maximum, and then the patient can safely be discharged back home. So now, how does ablation compare with antiarrhythmic drugs? So for this reason, we're looking at this trial, which is the Cabana trial. And this trial, this is the end result of it. So we're looking at event rate in percentage versus the time since randomization to drug therapy or to catheter ablation. So we need to know which therapy is the best. And by event rate, what events are we talking about? We're talking about death, disabling stroke, bleeding, and cardiac arrest. So if you look at this graph, you will see that catheter ablation is associated with much lower event rate compared to drug therapy. And this is why we are excited about this therapy. We are excited about this technique. We want to study it more. We want to know more about it. But if it's giving us, you might say, if it's giving us so much good results, why do we need to study it further? It's because of the following. Outcomes have been variable after ablation procedures, and this is because of the differences in techniques that are used. Also, the time of intervention. Also, some patient-specific factors. So some patients may have some other comorbidities that may have made them less suitable for such interventions. And because atrial fibrillation occurs and is a prerequisite in order for us to do this ablation, then the impact of atrial fibrillation can really have a lot of issues on the structure of the heart, on the electrical system of the heart, and on the flow, because we don't want to forget that the heart contracts and expands, and there's like flow dynamics that go over there. And we, in particular in the biofluids lab, we care about flow because it is associated with a lot of diseases, with a lot of responses, if we wanna put it this way. So how do we do that, and how did we assess the impact of ablation? This is the next part that I'm gonna turn it over to Brennan.
Okay, thank you, Dr. Hatoum. So what we're looking at here is the general workflow that we used for processing the AFib study. So working with our collaborators at Mayo Clinic, we received CT scans, which you can see under the image acquisition box. These CT scans are for patients who received ablation therapy for AFib, and we received them before and after they received their therapy. Each CT scan contains an entire cardiac cycle, and they're kind of the foundation for this entire study. We extract a bunch of information from them, and we can run a bunch of simulations from that data that we extract. So from these CT scans, using some software, we're able to create a digital 3D model of what a patient's heart looks like. So if you look in the image segmentation and processing box, to the far right, that's the left atrium, and that the structure that's like kind of sticking out of it, that's the left atrial appendage. So from this information, or from this data, we can extract the left ventricular volume throughout the cardiac cycle, as well as the mitral valve area. And this is very important because it allows us to derive the mitral valve velocity throughout the cardiac cycle. And we use the peak, which you see here labeled the E-wave peak, for a boundary condition later in our simulations. This technique is useful when we don't have echocardiographic information like you see at the bottom of the outlet boundary conditions box. So you can go ahead to the next slide.
Yeah, unfortunately.
Okay, so this is just a video of each segment of the CT scan. So they come in 3 different views: axial, coronal, and sagittal. And when the video plays normally, we can see the heart go through the pumping phase. And it kind of gives us an idea of where each heart structure is located, where each valve is, where the atrium is, and all that. So this is kind of what it looks like when I load it into the software for the first time. Okay, so once we have the models, using some more software, I generate a mesh that essentially coats the generated model from the CT scans. And we run a mesh analysis study to determine what the optimal element size is so that we have accurate results while also not wasting computing power. Because eventually our simulations require quite a bit of computing power to be able to calculate all of the hemodynamic values that we need. So after meshing, we run a computational fluid dynamic simulation. And from that, we're able to do a hemodynamic assessment. So in particular, we're interested in the velocity streamlines, the vortices, and the wall shear stress. And briefly, velocity streamlines essentially show us how blood or any particle in some kind of body will move. And in this case, with velocity, it shows us the velocity in different regions. Vortices, these are essentially a microscopic measurement of the rotational values of a fluid. And then wall shear stress, this is the force per unit area that the wall exerts on a fluid. And so what we found is from the velocity streamlines, it was kind of a mix. A lot of patients saw an increase in velocity while some saw a decrease in velocity. And then moving to the vortexes or vortices. Oh, sorry, can you go back real quick? So in the vortices, we saw some patients would have new vortex structures and some would lose vortex structures. And then since wall shear stress is the function of velocity, it's very similar to what we saw with the velocity streamlines. Some patients saw an increase in wall shear stress and some saw a decrease after ablation. And so if we go to the next slide now, we can kind of see what these velocity streamlines look like. So currently we're looking at the pre-ablation, and you can see the spheres that are moving around within the model. And if you pay attention carefully, you'll notice that some of them kind of stick around longer than others. A lot of them are escaping down at the large opening at the bottom. It's the mitral valve, which leads to the ventricle. And so sometimes these particles get stuck within the model itself before the next cardiac cycle would begin. And so then when we look at the post-ablation, it's significantly faster. It's easy to tell right away. And one thing to keep in mind is that these are, when we create the videos, they're created at the same speed as one another. So this is purely because of the velocity that the particles are taking on after the ablation has been performed. And one thing you'll notice too is that we don't really see any particles that are getting trapped like we were in the pre-ablation case. So if you go to the next slide.
Except in the appendage.
Yes, the appendage is a separate story, and it would require probably another presentation itself just to go over that.
It's the fingery thing up on the, up there, yeah.
Okay, so why is all of this important? Well, if we look here in the first box, we see the wall shear stress. There have been several studies that have shown that a lower velocity is indicative of increased thrombus or clot formation within the heart. And so looking at this box, we can see the pre-ablation, we have a bit higher of a wall shear stress than we do in the post-ablation case. So the darker areas are representing very low wall shear stress. So this is important because when we have low velocities and the potential for blood to clot, it also means that the wall shear stress is likely going to be low as well. And so it's been speculated that in regions of low wall shear stress, these thrombi are able to actually attach to the walls, and essentially there exists these pockets or zones of blood stagnation, and they're the perfect environment for these clots and thrombi to, or clots or thrombi to continue growing. And once they reach a certain size, or the wall shear stress for some reason increases, it can release these thrombi into the body and potentially lead to a stroke. And so studies have also shown that changes in the flow and vortex patterns within the left atrium can also lead to an increase in thromboembolic events. So looking in this box here, pre-ablation on the left figure, top left figure, we see 3 different vortex structures. They're pretty distinct. But then when we go to post-ablation, we only see the one. And then, like I said earlier, some patients either had a decrease in the amount of vortex structures between pre and post-ablation, and then the opposite for others. And so we're seeing that here in the right figure, where we go from one kind of defined vortex structure to 3 of them. And so this is important when we change these flow structures. It's very similar to the wall shear stress, where we're potentially creating these blood stagnation zones where the clot can form even more, and then again, potentially lead to stroke. So then if you go to the next slide. So this was an exploratory study. Like I said, we saw some patients see an increase, some patients see a decrease. There is no distinct trend, but what was really important about the study is it gave us an idea of what we need to look for moving forward for larger patient studies. So what our plan is now is to work with a larger patient cohort. And our hopes are that we're going to be able to start seeing these patterns emerge to where we can then work with clinicians, inform them about what they can look for, what we can see, and how they can essentially work with the patient to decide if ablation is the best treatment option for them, if an alternative would be better.
Excellent.
Thank you.
Very, very interesting. All right, and so folks, to ask a question, bring your cursor down to the bottom of the page, and there's a Q&A feature, and then just click on that, and you should be able to write a question. And the first one I read was Robert Carnahan's question saying, Janet, I was highly visible, jumping up and waving wildly Saturday night from the box. And Fridays was a better game. I know I was a little bit foolish. I'm sorry. All right. So Hoda, if you want to choose to answer a question, click on answer live or else Brennan, and then just read out the question and then go ahead and answer it.
Okay.
So I'm gonna read this question. Is the high rate in the US due to more ability to diagnose it? So basically these contours were by age and not by like higher rates. In the United States, this age range is basically prevalent, but definitely in a lot of areas in the world, there is really a lack of diagnosis just because it goes without symptoms or just people don't step in. So yeah, definitely the diagnosis option is very important.
Brennan, are you able to take your mask off or do you have other people in the room?
There's other people in here, unfortunately. I'm sorry.
Okay, well that answers that.
I can answer the next one if you want, Dr. Hattum, the one about the Watchmen.
Sure, go ahead.
Yeah, so the Watchmen is a device specifically designed to occlude the left atrial appendage. If you recall earlier, we mentioned it briefly. It kind of looks like a windsock. Sometimes they call it like a chicken wing. It has many different shapes, but the main purpose of this is to block the left atrial appendage. And if you recall from the videos that we showed of the particles moving around within the geometry, a lot of times those particles were getting stuck in the left atrial appendage. And so that goes hand in hand with our clot formation due to, blood stagnation in that left atrial appendage. And so when we occlude it, it helps us to stop that clot from being sucked back into the left atrium, where then it can embolize and cause a stroke.
Another question. Do people taking blood thinner like Xarelto have a reduced issue with AFib? So they have a reduced issue with stroke potential, because the purpose of a blood thinner is to basically resolve these blood clots that form to prevent a stroke, but they don't address the atrial fibrillation issue.
All right. I'm going to take one right now from Ronald. And so Ronald asks, how do we know what the next Husky Bites session will be? And so maybe Sue can put a link into our URL for mtu.edu Husky Bites. But we announced it in the pre-show. I usually have a slide explaining. And so if you want to watch the pre-show, I officially start my slides at 5:55 p.m. But in case you missed that, the next talk is going to be from civil engineering faculty member who is a world expert on using recycled materials in pavement. And so the title of that talk is Where the Rubber Meets the Road, because recycled tires are actually used in these road media. There, I've answered that one.
Okay. Thank you for everybody who liked the presentation. I'm reading some very nice comments. Yeah, there's this question from Sally. Is ablation never not a last resort? So it might not be a last resort, but sometimes it's the first procedure that people go to. However, historically, they start by giving people drugs, and if the drugs fail, then they start messing around more, so like messing around between quotation. But recently, a lot of studies are showing that ablation probably should be the first way to treat these people. However, as I mentioned, this requires a lot of attention to be paid on the patient population, because not all patients benefit, and AFib can recur again even after ablation. So ablation may not be like the one and only. Sometimes multiple ablations need to be done, maybe separated by months or years. So this is also another, it's actually a very complicated thing that currently we are trying to study, so we can help clinicians make some assessment on whether it should be the first line of therapy or it should not be, and when is it, who are these patients who would benefit from this, because not everybody benefits.
I can answer this next one if you want.
Yeah.
So with the question is, with the major hospitals in Michigan, are there any willing to participate in the study? And so, like I mentioned earlier, we have our collaborators at Mayo Clinic. And part of that is we work with here on campus, they're called the IRB. And it essentially allows us to exchange patient information between Michigan Tech, specifically our lab, and Mayo Clinic. And so we could work with other hospitals here in Michigan, but part of it too is that at least with Mayo Clinic, there's going to be a large patient population that we can pull from, whereas some of the ones in Michigan might not have as large of a pool. And it's also just about forming connections with these hospitals as well.
Another question. You mentioned differences in technique affecting outcome of ablation. Has anyone tried to find a correlation between the doctor performing the procedure and the outcome? Definitely, the expertise of the operator is a big factor, but no, I don't think anybody could find or studied that.
Another question here: are rates particularly lower in some other countries? So one of the things with AFib is that it's more of a disease or a problem in the elder population. And so in countries that have better access to healthcare and countries where people are living longer, you're going to see a higher likelihood of patients developing AFib over time. And so in other countries where access to healthcare is a little bit less, you also run into the issue of not being able to actually diagnose patients with AFib. They might not be able to afford healthcare or whatever it might be. So that's kind of why you see some discrepancies between the countries.
Another question, have you done any research regarding left ventricular non-compaction? No, unfortunately, I haven't had the chance to look into this this disease or this muscle disorder, partly because it's more related to muscle than flow. Definitely the flow is impacted, but I never got the chance to work with such patient population. Brennan, do you want to go next?
Yeah. So this question is, what is the function of the appendage? The short answer, we don't really know. There's a lot of studies trying to determine why the appendage is there. A lot of people think that it's just a visceral organ, and some think that it has a lot of potential for different flow environments within the heart. And so we're still not really sure, and it's kind of the $1-million question right now. What is its actual purpose? So there's a lot of studies that are looking into it right now.
Okay. Can you use actual data in addition to the CFD to add to your understanding? I had arrhythmia a few years back where they used ultrasound to identify some moderate flow regurgitation through my aortic valve. So yes, so this is what we meant by boundary conditions when Brennan started introducing the computational fluid dynamics that he needed. So when we want to run these simulations, we look at the echo data, of course, if available. Not all patients have this data. But when this data is available, then we look globally at whether the patient has any aortic heart disease, any mitral heart disease, any regurgitation, any stenosis, or anything remotely related to the left side of the heart overall. And even some studies are showing that the tricuspid valve, which is located on the right side of the heart, can have some influence. So we account for all these factors in whether in the patient history or in our boundary conditions when we want to run these simulations. Okay.
So a question from James. Hoda and Brendan, what drove your interest in this type of study?
Right. So I just realized we missed a question. That's why I got a little bit confused. So basically, this study was brought to us by our collaborator at Mayo Clinic. He was very eager to understand whether ablation has any negative impact or positive impact overall, because he wants to understand more the story. And our collaborator is a clinician, so he just brought us the problem. Just like other collaborators, this is how we operate basically in the lab. We have these collaborators, they bring us problems, and we try to devise solutions for them, whether experimental or computational solutions. And AFib is like a very underexplored territory. So we do our best to like try to find these very important problems that are not tackled by everybody, so that we gain some identity, one, and two, we have some more impact on the field. There is a question that we missed, I guess, any correlation between genetics and flow patterns. Definitely genetics are very important because they determine the predisposition to develop a certain disease, but an actual and a one-on-one comparison or correlation between genetics and flow patterns has never been done. And in order to do that, we basically look at the outcomes of the genetics. So let's assume that it's because of a genetic disorder or a genetic factor that somebody, like it runs in the family, let's say, if we're looking at an AFib patient. So this definitely might have an effect, but to actually have a direct correlation, this is like nobody has studied this before, and I don't think that we can actually study it using our methods.
So is atrial flutter different from issues for AFib? They're the same disease, so both are just an arrhythmia issue.
So sometimes, to add on that, these arrhythmias can have different types, but like for example, atrial fibrillation is a type of arrhythmia. Atrial flutter can involve something else. So it might not be the same, but basically they fall under the same umbrella of rhythm irregularities. There's a question by Sarah.
Yeah, I can answer it if you want.
Yeah, yep.
So the question is, I'm curious about CFD simulations. Could you explain the boundary conditions a bit more? Are the heart walls treated as flexible? How is the inflow treated from the scan data? So, like I mentioned, sometimes we have to extract the left ventricle volume, and that's what allows us to calculate our outflow boundary condition for the mitral valve. We set that as a velocity outflow, or in the software, it's a velocity inflow, but that's a bit too much detail. But other times we have echo data, which gives us what the mitral valve velocity waveform actually looks like. And then we use an online resource to essentially look at the values of that waveform. And then we can select the location that we need, in this case, the E-wave peak. And then as for the heart walls, they're treated as rigid in this simulation. But in future simulations, we might start to look more towards FSI.
So Brennan, if I can weigh in on this before you keep going.
Yep.
So basically the reason why we segment the 20 phases in order to get to the difference in volume and select the E-wave precisely is to overcome the inability currently, unfortunately, but we're working on it, to implement compliance in our wall. So if we could implement compliance, then our outflow boundary condition could have been taken as the mitral valve curve. But because we don't have this compliance of the atrium, because the atrium is an active structure, it's not like just stagnant, it contracts. So to overcome that, we do this derivation that Brennan introduced in his step 1. So we can know what the shape of the atrium looked like at that particular point, so we can apply this boundary condition. You know, so this is like very important to emphasize, because of like we try to overcome the limitation of not applying compliance by selecting how the atrium shape would be through doing the different LV geometries and then selecting the appropriate mitral velocity that eventually connects back to what was the shape of the atrium, what phase was that on the CT scan, so we could extract it.
And so one thing too is when we receive these CT scans, they have 20 different phases of the cardiac cycle. And so our derivative is a little bit limited by those 20 phases. So if we had, say, 100, our resolution would be a lot higher. We'd be able to see nice curves, but unfortunately, the people recording the CTs only feel comfortable doing the 20 cardiac cycle or 20 phases. And then the next part was, how is the inflow treated? The inflow comes from the pulmonary veins or arteries, and we do a pressure inlet at those. And then from scan data, yeah, sometimes we can extract some scan data. So in particular, we need to match the heart rate up to make sure that when we're calculating our left ventricle time derivative, that we're actually using the heart rate that applies to the patient. So we're not just setting a standard 60 beats per minute for every patient. It's specifically for each patient.
Another question, and I want to thank the feedback from Ward Christensen. Another question by Thomas Wade. Do you have a time frame for increased data participation? So we do not do the clinical trial. We don't recruit patients, and we don't do our study prospectively. We use retrospective studies, which means that these patients are available, let's say, from 2015 to 2020. They have pre-ablation and post-ablation CTs, and they are basically patients of Mayo Clinic. So we get this existing data and we use whatever we have. We don't do prospective and we don't recruit patients into our studies. And this is basically how the IRB, how our IRB is set up with Mayo Clinic currently. How does a pacemaker work in conjunction to these other treatments? So it depends. A pacemaker was at some point used in order to treat that, but it was shown that it wasn't enough. But for example, if a patient has like a transcatheter aortic valve that is implanted and then they needed a pacemaker to be there, then definitely the clinicians would have some way to coordinate that. But more information on that, unfortunately, I can't tell. Yeah, a clinician is better suited to answer this question.
This question is, do you get any funding from large companies that make medical devices? Not currently, no. There are some labs that do work with medical device companies, but usually that type of thing is reported in any publication that we have for conflicts of interest, etc. But short story, no, we don't currently work with any.
But you'd be willing to.
That would be up to Dr. Hattum, yeah.
Are you able to combine echocardiograms with your data to enhance results? So currently the limitation of combining both is the time basically that of both. Current simulations and current studies done by other labs for multiple other reasons, not necessarily AFib, they run echocardiogram related simulations on their own and flow simulations on their own. So a way to combine both given the limitations is something that is currently under investigation. So currently we do not do that.
Yeah, another thing too is that we can use those that data for validation purposes for the pulmonary arteries.
Yeah.
So when this ablation takes place, it's through a catheter, right? So they're
It can be surgical and it can be through a catheter. Yeah, unfortunately the video didn't work, so that catheter ablation it's shown, but basically it's a catheter that they insert from the groin and they just push it. And once they monitor where it's going, and once it reaches the area of interest, which is pulmonary vein, they make they use this, and the tip of it uses some cold energy, very cold energy, or a hot energy, and they burn the tissue. So when the tissue is burnt, then the electrical impulses that are abnormal and basically like going all over the place, typically from the pulmonary veins, they cannot propagate anymore. So this is the way to restore the rhythm.
so That's if it's via catheter, and surgically.
That surgically, they just, it's a highly invasive procedure. So they just open it and they do the scarring I guess in an easier way than a transcatheter, but I'm not sure if it's easier just because they can see things.
Mm. Okay.
Yeah. Yeah.
I'll answer this question since it's similar to what we were
Right.
just talking about. It's how many types of ablations exist. Like we mentioned, there's radio frequency ablation. And so that there's essentially where it burns the cells away. So very high temperatures. There's also cryoablation, which uses the cold to do it. And then there's also surgical ablation, which we were just talking about, where the chest is actually open and they apply the radio frequency that way.
There are a lot more types, but really, like we can mention 5-6 types overall. And the more the technology is ongoing, the more we're seeing much more. There's a question: you haven't mentioned surgery to install a pacemaker. Where does a pacemaker fit into this discussion? Sorry, let me mark it. So basically, the clinician can recommend installing a pacemaker. So, but the pacemaker are used to treat a slow heart rate or like a heart rate. As we said before, the therapy has shifted towards looking at antiarrhythmic drugs instead of drugs or therapies that fix the heart rate. So this is why I'm not sure whether anybody still recommends just installing a pacemaker along with anticoagulation. Were you surprised with the similar results? The similar results in terms of increased velocities or... So we were surprised with the different results, to be honest. We expected some very favorable results in all the patients, and we thought that this is it, like ablation is the savior, like increased velocity, very nice shear stress, etc. But we were surprised to find that in some patients, it did not lead to that, although they share same baseline characteristics. And this is what challenged us, or what encouraged us to continue looking at more homogeneous patients who share, for example, the same baseline conditions, so we can isolate whether ablation really is suitable for these patients or not.
And this is also what makes this work also very interesting, is that when we move to a larger patient population, we might start to see large differences. And I think that's just a really cool next step.
Right. Can the Watchmen allow patients to stop the use of blood thinners? So this is the aim of a Watchman, is to basically close the appendage in order to prevent any clot in case they form to embolize. However, this is not like not all patients can stop blood thinners. There's some issues sometimes with the Watchman, for example, some leaks that happen and some spaces like the contact is not fully achieved around it. So some things may embolize. So it's not 100% a guarantee, unfortunately, but some results of like some new trials are showing very promising results. So like fingers crossed for the Watchman and other occluders of left atrial appendages as well.
I'm impressed with how much our audience knows about the heart stuff.
Yeah, especially arrhythmias. I mean, it's okay. Is the Center for Individualized Medicine at Mayo Clinic looking at genetic predisposition for results of ablation? I'm not sure, but at the same time, I don't think so. But I'm also not aware of the center's activities. Do patients at Mayo have to give permission for use of data from their procedures? So there is a consent form that the patients need to fill in order for clinicians to use their data. By the way, the data that we use are de-identified, anonymized, so we don't know anything about the data. We don't know the gender, we don't know, absolutely not the name, not the birth date, nothing like that. We just get patient 1. This is what it looks like. This is what their heart geometry looks like. That's all we do. So, but usually there is a consent form, and definitely Mayo takes care of these details.
Yeah, we very strictly follow our IRB.
Can you elaborate on electrical impulses issues and the AFib and any difficulties in determining a ablation location? So during ablation, they actually have a software where they see where they should ablate. So this software can guide where these abnormal impulses are being seen, and they guide the clinicians into ablating the right spot. So hoping for the best. However, that doesn't mean that after ablation, it's 100% guarantee that regular rhythm will be restored and that AFib is not gonna recur. Sometimes it does recur. Are there environmental issues which can increase the incident rate, or is it purely physiological? To be honest, for example, it is purely physiological, I should say. And we mentioned, for example, aging is a factor, obesity is another factor. So it's not really environmental, if that's what I understood by environmental. What influence would the exterior deformation have on your studies? So currently, we're doing our best to simulate a phase, a specific phase, so we can see the flow in that specific phase. So it's like we are fixing a point in space and we are running these simulations. If we could run a larger simulation with like all with the compliance of the atrium and with the opening and closing of the mitral valve, then we probably should see similar flow patterns, not similar 100%. There might be some differences, but not that would affect the overall patterns or the overall magnitudes of the flow. We should also mention that knowing the material properties in order to simulate that is very challenging. And until now, nobody really knows exactly. Like we could not extract, for example, a piece of atrium and do some testing on it so that we can understand whether the stiffness is variable or not, or whether it's constant or not, or how we can implement it. So we do our best to resolve the problem as closely as possible to reality, but at the same time, we do acknowledge that we are not 100% there.
So you don't have any patient history. So for example, if a patient had experienced radiation to solve lymphoma 20 years ago, you wouldn't know in your simulations that they had harder arteries or a stiffened heart.
So we do look at patient baseline. So for example, we know if the patient had hypertension, which leads to like these stiffened arteries. We know whether the patient had surgical ablation before, let's say, or a procedure that has been done 5 years ago, let's say. This is the type of baseline characteristics that we look at. And in this study, we found that a lot of these patients, if not all of these 10 patients, had like multiple cardioversions. They have multiple, at least 6 of them had a previous ablation procedure done. So they had recurrent AFib. So we do know their history. If we if we want to like find more factors that would be, for example, predictors, or that we doubt that they might have an effect. But definitely we don't know everything. We don't know the whole picture. We know cardiovascular events mostly. Any comment on the recent heart patient who had a pig heart as a replacement? Like, to be honest, kudos to the doctors. Hopefully he survives, and this would be like really opening a new page in medicine and allowing a lot of people to leave the waiting list to actually have the hearts that they're waiting for. Yeah.
So we are coming up on the end of the hour, and I want to compliment you both because you have answered more questions than I think anybody else has, and they were coming at a really rapid pace. So each of you pick one more question. I know we have 8 open questions. Maybe you can get them done in 2 minutes. Ready, set, go.
Okay, let's see. About the Brennan, do you want to go back and revisit the Watchmen and the blood thinners? Or maybe it was me who answered.
It was you who answered.
Yeah.
Okay.
The Watchman is supposed to do the job that the blood thinners are doing, which is block this appendage. So in case any clot forms, it stays there. It doesn't embolize. However, this is not very true, and it's shown in a couple of papers that have been published recently. So these, in some patients with Watchmen, they are still on anticoagulation. And sometimes it might be because the Watchman doesn't seal very well the appendage wall. So the contact is not 100% achieved. So that's one unfortunate event connected to the Watchman. However, a lot of studies currently are being done in order to figure out whether the Watchman should be implanted at level 1 or level 2, like in terms of axial position with respect to the appendage. Are the non-Newtonian characteristics of blood difficult to model? No, they're not difficult to model. We can model them, although in our study we modeled the Newtonian and not non-Newtonian.
I can answer this one.
Okay, sure.
So I'm not sure about a TAA, but I do know that a TEE, which is a transesophageal echocardiogram, is used in conjunction with implanting the Watchman. So there's that. I don't know, maybe Dr. Hattum knows about the TAA.
I don't, but even when things are shown, because they're not in 3D usually, there's a limitation on how much you can see in 2D. So, and sometimes the size also matters, because the Watchman comes in like 3 or maybe 3 different sizes. So what if a patient has a size in between, for instance? Usually they go for the larger one, but still the Watchman has a specific geometry. The entry to the appendage has a different non-regular geometry. So this may lead to some holes in the contact.
Yeah, and part of that too is the Watchman has just so many different sizes. Like we have a couple here, and you can see they're all different shapes and sizes. And so sealing is kind of an issue when every patient is different and everyone has a different size left atrial appendage.
And the Watchman is Boston Scientific, that's correct. And the implants, we know about the implants as well. And we make mapping systems to find errant. Yeah, we are totally aware of this. Thank you for the feedback on that.
And that's the Abbott brand.
That's right, yeah.
The question on the environment, so while some areas of the world have less, this again is just, it's partly an age thing. So in countries where access to healthcare is easier, let's say, these patients are usually living longer. And we know that AFib has a pretty strong correlation with developed or aging populations. So people who are 65 plus are more likely to develop some kind of arrhythmia. So in countries where that might not be the case, that's why we see a decreased level. And also it goes hand in hand with having access to healthcare and being able to diagnose if a patient has it or not too.
And the last question, I guess, during ablation, how many nerve paths are zapped on average? I'm not sure, to be honest. A clinician is better suited to answer this question. So yeah.
All right, that's 56 answered questions. And how many people were watching? We're between 150 and 200. We had we're in that neighborhood. So that was the last question Warren was just asking. And I wanted to comment. So first of all, thank you, speakers. Thank you so much for your patience answering all these questions and your knowledge. I'm going to do a caveat. Nobody here is a physician, so don't take any medical advice from any of us, please. If you want medical advice, you should go to your very own doctor. But we learned a lot, so much, and so thank you very, very much. We will see you all next week, where the rubber meets the road, which should be a really interesting talk. And so Dr. Hatoum and soon to be Dr. Vogl, thank you for your time and interest, and happy Valentine's Day, everybody. See you next week.
Thank you so much. It was
Thank
really
you for
great.
having us.